Thank you. Nice to see the greetings in the chat. And I'm just briefly pausing so that we can have the recording button started. I should also mention as well too that closed captioning is available and can be turned on. So this event will run for about 1 hour until approximately 8 p.m. Eastern Standard Time. And we, again, really appreciate your presence. While we're working on getting things going, I did want to briefly mention a very exciting announcement for those who are not aware. But CDM will be hosting our very first in-person health summit in Toronto on Saturday, March 8th from 9 to 5. We have a few folks registered so far, but we have far more capacity, or definitely not too late. We'll have about 100 healthcare advocates, physicians, medical learners coming together to discuss the hot button issues of our healthcare system. We have quite the exciting program and lineup for us. So if you like events like this, I think you will love the in-person health summit. So if you haven't already registered, please check your email. There's information on our website. And I see that Sarif, our national director, just put the link within the chat. All right, but back to why we're all here tonight. We are thrilled to welcome Dr. Gregory Marchildon, the author of Tommy Douglas and the Quest for Medicare in Canada, the lovely book that I have right here, for an engaging discussion on the origins and evolution of universal public health care in Canada. And at a time when public health care urgently needs reform, we're looking forward to reflecting on key lessons from history to inspire meaningful, transformative change today. For those who don't know, Dr. Gregory P. Marchildon is a professor emeritus at the Institute of Health Policy, Management and Evaluation at the University of Toronto, and the founding director of the North American Observatory on Health Systems and Policies. As a scholar practitioner, he has extensive experience in establishing and working in national and international research and policy networks. His research focuses on the history of public policy, with a particular emphasis on comparative health systems and policies. He is the author of numerous books, articles, think tank papers on these subjects, including the book we're here to discuss tonight, Tommy Douglas and the Quest for Medicare in Canada, published by the University of Toronto Press. Dr. Marchildon has worked in 3 professions in his lifetime, much like T.C. Douglas or Tommy Douglas, who we'll be discussing. He's had multiple professions and worn multiple hats. Dr. Marchildon has worked as a lawyer, criminal prosecution and defense, as an academic at institutions like the London School of Economics, Johns Hopkins University, the University of Regina, and the University of Toronto, and as a public servant, serving as a Deputy Minister of Intergovernmental Affairs and Deputy Minister to the Premier and Cabinet Secretary in Saskatchewan, as well as Executive Director of the Royal Commission on the Future of Healthcare in Canada. He is a well-deserving member of the Order of Canada and a Fellow of the Canadian Academy of Health Sciences. At this point, I would love for you to join me in a virtual applause for our esteemed speaker tonight, Dr. Gregory Marchildon. Dr. Marchildon, welcome, and please take a minute to set up your slides.
Thank you very much, and I'd like to thank you, Mel, and as well as Zarif and Canadian Doctors for Medicare for inviting me here. And I'm going to try to share my screen. And basically, what I'd like to do this evening, and I'll just go back one screen because I just want to quickly explain my motive for writing the book and why it has taken so long. I basically got an advance contract for this book back in 2001, but then ended up in a series of engagements that had me dealing with contemporary policy, including the Romano Commission, and then after that, working very closely with the European Observatory on Health Systems and Policies on comparative policy, and dealing with various issues for both governments within Canada as well as international organizations, mainly to do with universal health coverage, how to implement, how to get started, how to finance, how to manage. So I had very little time to work on history. I did take some time to do the occasional, what I would call policy-heavy article on the history of Medicare. Did a lot of comparative work. I decided that I wanted to make this one of my sort of, in a sense, major destination points in life to get this book done. Initially, it was to be a history of universal health coverage, but I also ended up doing some work on Tommy Douglas, including a biography for the Dictionary of Canadian Biography, and it made me realize that it was very hard to disentangle Tommy Douglas from Medicare and Medicare from Tommy Douglas. And the more I looked at it, in fact, the more I realized he was implicated at all stages of universal health coverage, it's basically a 50-year story. And he was at the center or close to the center during that entire half century. So I decided to make this a combination biography and history. And I also thought it would provide a very neat biographical narrative to what can be a very, what I would call policy and administrative heavy history. And so I was able to, in a sense, inject personality as well as I think some of the key essence of Medicare beyond the policy and programs. So I'm going to just give you first a quick overview of the book and to explain that it starts actually in the middle of his life, the pivot point of his life, which was the 13th of October, 1961. That's the first chapter. And the reason that I present that is I want to take you into his life in the Saskatchewan legislature on one day when the bill on universal medical care coverage is introduced and then goes to second reading. I wanted to be able to explain both Douglas and the way that he would have looked back on his life, what he and his government had accomplished and what he was still trying to accomplish, and some of the anxieties that he held about the future, given that he was already running into serious and I would say severe opposition to his bill. Then the book follows a typical chronological order. It starts in the next two chapters with his life as a Baptist minister and a member of Parliament during the Great Depression, and centers his motives and his desire to change the status quo in terms of the shock of the Great Depression and the radicalizing impact that it had on him. Then there is a whole group of chapters that deal with his role as premier from 1944 to 1961, when universal hospital coverage was introduced in his first term of office, as well as regionalization. I'm going to spend a little bit more time on regionalization and what it implied, because I think that is part of the history that is largely forgotten now, as well as some of the other areas that he tried to initiate major change that as well are not as well known, if I can put it that way, as universal health coverage. Then the last third of the book, it relates to him as national leader of the New Democratic Party. He held that position from 1961 to 1971, then as member of Parliament till 1979, when he stepped out of his role as an MP, and then he became an advocate for Medicare. And by Medicare at that time, what we meant was the extension of universal hospital coverage to universal medical care coverage, which became known as national Medicare. But in Douglas's mind, it was always about comprehensive health coverage, and hospitalization and medical care were only the first two steps of a multi-step process that would ultimately produce comprehensive health coverage. And then his last years as a defender of Medicare, his great concerns with the block funding formula that was introduced by the government of Pierre Trudeau in 1976 and 1977. His support of a new law that would eventually be called the Canada Health Act that would shore up some of the deficiencies of the earlier Federal Medical Care Act of 1966. In particular, the fact that extra billing and user charges had become a regular part of the Canadian landscape, even though that was not what was intended when universal hospital coverage and later universal medical care coverage was introduced nationally. So let's go back to 1944 when Douglas and the CCF were first elected in Saskatchewan. And Douglas did something that was very unusual. He appointed himself Minister of Health. And he did this because out of all the things that that government wanted to accomplish, he felt that the first most urgent thing that needed to be done was a major transformation of the health system in Canada. And he intended to attack that in two ways. One was through health insurance, and the other was through what I call integrated health regions. Both tracks were difficult and both tracks were extremely expensive. Both tracks also involved a lot of change and innovation. And in both areas, Saskatchewan was, in a sense, a first mover, and there weren't a lot of models and examples to draw from in the rest of the world. The next thing is, even though they seem like two completely separate tracks, Douglas saw them as mutually supportive and attached a great deal of importance to each track. And in both, doctors were deeply involved. And this is what I would like to now focus on, is Douglas's relationship with the medical profession in this first phase of reform. With universal hospital coverage, Douglas thought that he had the doctors, even if grudgingly, accepting, at least going along with universal health hospital coverage. And that was because as soon as he was elected, within months, he wanted universal coverage for public beneficiaries. It was a targeted group, poor group, pensioners, widows, and I could go on and on describing the group, basically people that were public beneficiaries in some form. And he wanted to ensure that they had access to all hospital and medical care free at the point of service. So he knew it would take a couple of years to get the new program of universal hospital coverage designed, and so he focused on at least targeting that particular group in the meantime. The representative of the doctors at the time was the College of Physicians and Surgeons of Saskatchewan, because in the 1930s, they had forged a sort of a single organization out of the Saskatchewan Medical Association and the Regulatory College in order to save money during the Great Depression. But that meant that the political body of the doctors was the same as the regulatory body. And we can talk a little bit about some of the problems that caused. That remained the situation until the latter half of the 1960s. When Douglas talked to this organization, the College of Physicians and Surgeons of Saskatchewan, about universal hospital coverage, they made it clear that they wanted co-control of governance and the establishment of an independent commission in which the doctors would form basically half the commission. Even though the doctors insisted that universal coverage at that stage be limited to hospital care and diagnostics and not cover physician care. Douglas basically only half agreed. He already had an organization called the Health Services and Planning Commission. He said, well, that's sort of arm's length. But the doctors, of course, did not agree that that's what they meant by it. Nonetheless, the doctors benefited both financially and psychologically from the hospital plan that was implemented in 1947 because all of a sudden their patients could get at least a free hospital stay. They would only have to pay their doctor's bills, and this made it much easier for them to pay their hospital bills. Second of all, psychologically, doctors knew that their patients could afford hospital care now, and so they weren't afraid to send them in for surgery or whatever procedure they needed within a hospital. And this changed the dynamic quite substantially because doctors would be, in a sense, were careful if the patient couldn't afford hospital care in the past, they would sometimes try to suggest other means or try to suggest that there could be some at least marginal things done, but that they couldn't get the main operation completed at the hospital. Even though the doctors benefited a great deal from universal hospital coverage, they were concerned about extending the principle of universality to medical care, and they remained very concerned about that throughout the 1950s. And I'll come back to that in a minute. But let's talk about integrated health regions. The college was also opposed to this idea. In fact, they very much disliked these local governments that constituted the health regions running their own hospital and medical programs. And the one that got out ahead right away was Swift Current. The Swift Current Health Region immediately implemented, even before the province moved on universal hospital coverage, immediately implemented medical care and hospital coverage for all patients that lived within the health region. The doctors were very much opposed to that, and they were also opposed to the extension of the municipal doctor plans, where the municipalities hired doctors, many of them on salary, and they really did not want that precedent continuing. So they argued in favor of providing municipal doctor plans with a fee-for-service kind of model contract that could replace the salaried doctor contract. By the mid-1950s, they were competing for the business of the health regions through their own insurance carriers. They were saying, you don't need a municipal doctor plan. Just enter into a contract with us, a physician-based carrier, and we will provide medical care coverage for you. This was through Medical Services Incorporated and Group Medical Services, the two big physician-based plans in the province. They saw the health regions really as the kernel from which socialized medicine would grow, and that these health regions were a threat to the traditional family medicine practice and the business autonomy of physicians as they saw it. Now, this was organized medicine speaking, not necessarily the physicians that were working in rural areas, but the executive, if you like, of the College of Physicians and Surgeons of Saskatchewan. There were key doctors that supported change in opposition to the College of Physicians and Surgeons, but almost all were outsiders. Dr. Hugh McLean had lived in Saskatchewan for a long time. He was tried to be an MP at the same time Douglas became an MP. Douglas got to know Hugh McLean quite well in the latter part of the 1930s. But by the 1940s, McLean had moved to California, where he lived the rest of his life. And he was invited back from time to time, including in 1944, to talk to the caucus and cabinet shortly after the swearing-in ceremony for all the cabinet ministers. The next person was Professor Henry Sigaris from Johns Hopkins University, Swiss by origin, and probably the most famous professor in the world in the late 1930s and early 1940s. And Douglas managed to convince him to come to Saskatchewan and head up what became popularly known as the Cigarettes Commission. And so in September of 1944, he traveled through parts of Saskatchewan. And then with the help of Dr. Mindell Sheps, who supported him through the Health Services Planning Commission, or the predecessor to it, who was a more radical doctor from Manitoba, who was a young physician at the time. She was also Jewish. Her husband came with her, and her husband took over from her in the Health Services Planning Commission when she decided to step down. And then shortly after that, they both moved to the United States for graduate work, again connected to Dr. Henry Sigrist. But the point here is that both Sigrist and the Sheps laid down a blueprint that could be implemented by the government of Saskatchewan that at its center involved integrated health regions and secondarily health coverage. The next group of doctors that supported Douglas and his efforts was a group from the United States who had worked on the New Deal programs for rural health and had run rural health insurance programs for poorer farmers in the drought-stricken regions of the United States, as well as transient farm workers. Fred Mott had a huge amount of experience. He brought with him Len Rosenfeld and Milton Romer, and all of these individuals would face problems in the United States in the post-1945 period due to the sort of McCarthyite climate, increasingly as a product of the Cold War. But they enjoyed what I would say is a golden period in Saskatchewan as the Cold War was making things very difficult in the United States. And all three were critical to the design and then implementation and management of universal hospital coverage. So none of this happened in a vacuum. And Douglas was critical because he recruited every one of these individuals. He went to Washington to convince Fred Mott to leave the Farm Security Administration and the U.S. Public Health Service. He was basically the second in command at the time. He had a huge job, and he convinced him to come to Saskatchewan to be chair of the Health Services Planning Commission and to be the Deputy Minister of Health. So health insurance versus integrated health regions. I'm not going to spend much time on this, but just to understand in terms of the health region side of it is that you were trying to build a coordinated system, largely in the rural areas. The municipal governments were in charge. They basically, local governments had to vote on whether to create a health region and then had to create the infrastructure. They were supported by provincial grants as well as salaried individuals by the Department of Public Health that were sent to the health regions to work with the local governments through the health regions. Their facilities were largely publicly owned. They were, in fact, local government-owned facilities. They created a hierarchical organization of hospitals to primary care clinics. And this was really the first major effort to create health regions in the country, and nothing like it would exist again until the 1990s in Canada. This shows you how slow the process was in terms of the date of organization of these health regions, because they required the support of all the local governments before they could be established. In Douglas's mind, the principal rationale for health regions was to provide an administrative base for full-time public health services. That was the core mission. And each region was assigned a medical officer of health, public health nurses, and public health officers, what were then called sanitary officers. The region's Health Human Resources really encouraged programs and individuals to combine population health services with individual curative services. The Department of Public Health helped out by setting up new divisions. And Sigrist, as he had recommended in 1944, said there needed to be a new kind of medical school established to integrate social and medical dimensions of health together. It needed to be a new curriculum. I'm just going to quickly give you a bit of a footnote to show you how this was integrated in health regions by talking about Dr. Vince Matthews. He was the medical officer for health for Swift Current Health Region. He was a medical grad of the University of Toronto, but he grew up in rural Saskatchewan. He decided to create a very strategic use of vital health data using vital stats to create a statistical card for children, eventually including preschool and then school data. The data was provided to public health nurses to pinpoint and address potential issues, both on a population and an individual basis. And he scrutinized the causes of death recorded by physicians to get a proper classification and a proper statistical basis. He used this really to build up quite a remarkable system, and this became then the building block for public health surveillance, eventually adopted in all the health regions with support from the provincial Department of Health. In addition, Douglas had made, in 1944, made all psychiatric care free of charge. The clinical care was free, but none of the custodial care, if you could afford it, you had to pay for it. But he basically made it free, created a psychiatric services branch. It was the largest division within the Department of Public Health and one of the largest agencies within the provincial government. It really spearheaded a huge shift from the idea of confinement of the mentally ill to the treatment, care, and prevention of mental illness, and a focus on community-based care, research, and addictions treatment. Involved a lot of educational programs and a new psychiatric nurses program, as well as a number of experiments with various what I would call treatments, as well as experiments in changing attitudes towards mental health care. Phase 2, universal medical care. That wasn't possible until national hospitalization was introduced a full decade after universal hospital coverage had been introduced in Saskatchewan, but it became the template for national hospitalization in Canada. And when the Douglas government received its first dollar for dollar cost transfers from the federal government through the national program in 1958, this allowed him and his government to move to the next stage, which was medical care. And at this stage, organized medicine was very much opposed. And in fact, the College of Physicians and Surgeons was very supported by the Canadian Medical Association, the Ontario Medical Association, and the American Medical Association, none of which wanted to see a beachhead in universal medical care coverage in Saskatchewan because of the knock-on effects in the rest of Canada and the United States. To add to that polarization, the National Health Service had been and was popular in the United Kingdom, but doctors were a little bit divided on it. In fact, there was a very vocal minority within the United Kingdom that were against the National Health Service, and they emigrated to Canada because they said, well, there's no There's no National Health Service in Canada. And then they arrive in Canada to find out that there's a consideration of universal medical care. And they really serve to harden both the provincial medical associations and the Canadian Medical Association against Douglas's design. Douglas set up his own public committee called the Thompson Committee to reach out to the doctors and to other stakeholders in the province, put forward basically a design, but then asked what needed to be, in a sense, reshaped to meet their concerns. And the doctors, through the College of Physicians and Surgeons, and they had 3 seats on the Thompson Committee, decided that rather than try to compromise with the government, they would in fact engage a policy of obstruction, and they delayed and delayed the production of a report. This really reflected a huge miscalculation by both Douglas and the College of Physicians and Surgeons. On Douglas's part, he thought that once the doctors knew that the government was absolutely committed to do this, they would come to their senses and begin to compromise. The miscalculation of the college was that if they could obstruct, delay, and get enough other groups, including the business community, other professional groups on side, as well as the national organizations, that they could actually stop Douglas and the government from implementing universal medical care coverage, maybe at worst get the government to drop its universal plan in favor of a means-tested, targeted plan that would subsidize private health insurance. Both were wrong in terms of their calculations of the other. So the anti-Medicare forces really mobilized in that period of between 1960 and 1961. And when the bill was introduced in the House and went to second reading, it became national news, and the opposition grew and grew. And Douglas suffered a number of political defeats in a very short period, starting with the Weyburn by-election in his own provincial constituency, which he had to give up to become national leader of the New Democratic Party. And the NDP was beaten by the Liberals, largely in an election that involved Medicare. And then a series of Ontario by-elections in January of 1962. Again, Medicare fared poorly. It wasn't a salient enough issue to take the day. And in fact, the NDP did very poorly in all of the by-elections. Then Hazen Argue, who had been the parliamentary leader of the CCF until Douglas was elected in the new party, the New Democratic Party, and then Hazen Argue defected from the NDP, using Medicare as his main argument that it was too much of a state-imposed policy. And then Douglas's former Minister of Health, Walter Erb, resigned from the provincial government in March 1962, again citing Medicare as the reason. And then finally, and most obviously, the humiliating defeat of Douglas in the federal election of June 1962, where he was absolutely trounced by his conservative opponent. And he found himself a federal leader without a seat in the House of Commons and had to move to British Columbia eventually to get a seat in Burnaby. Right after the federal election in June, there was the 23 doctors strike in Saskatchewan. And again, Douglas was at the center of it, even though he was no longer premier. As you can see from these protesters from the Keep Our Doctors Committee, the women on the right of your screen, who hung Douglas and Woodrow Lloyd, the premier at the time, in effigy, and held Douglas in particular responsible for what they considered to be the travesty of Medicare. The strike only came to an end with the Saskatoon agreement, and the costs for the agreement were high on both sides. And by that I mean a price that both hated at the time and probably came to regret many years later. For doctors, the compromise was they had to accept the essence of single payer, if not the form. They created a kind of a temporary arrangement where their medical services incorporated and group medical services could be used to pay their patients, but it was really a pass-through. It was really the government that was paying all patient bills. They also had to live with the threat of alternative primary care practice through the community clinics that have been set up to support Medicare. And they had to live with the fact that there was now a beachhead for universal medical care in Saskatchewan. For Douglas and for the provincial government, the compromise involved the right of doctors to opt out of the plan. That was never intended, but they had to accept that. They had to accept that the Medical Care Insurance Commission that was responsible for administering the plan privileged fee-for-service over salary, and they had to put up with the alternative modalities of payment through, as I said, MSI and group medical services. This is a cartoon from the time, basically poking fun at Douglas for using Medicare as his election issue, the fact that it didn't work outside of Saskatchewan, and within Saskatchewan it kind of backfired and blew up on him, and that as a consequence, both he and the NDP suffered greatly as a consequence of his stubborn insistence on Medicare being the central issue of the 1962 federal election. I've already talked briefly about national Medicare, and I'm going to save some of this for the questions and answers, but this more recent history you will be familiar with. He was the NDP leader in a 10-year period where during many of those years, basically it was a minority government. Both Pearson governments were minority from 1961 to 1968. And Douglas and the NDP held the balance of power, although it was extremely fragile because the NDP did not hold all that many seats, but just enough for the balance of power. And of course, supported the Medical Care Act of 1966. But by the 1970s, the NDP did not hold that position of power, particularly after 1974, and could not stop established programs financing and block funding, replacing shared cost funding, but later on could push very hard for the Canada Health Act, and in that had a strategic ally in the person of Emmett Hall, both in terms of the Hall Commission report in 1964 that clearly supported Saskatchewan-style universal Medicare with its single payer and its single tier design, as well as the report to the federal government by Emmett Hall years later, where he said that they needed new legislation to deal with this onslaught of extra billing and user charges. So on that, I think I've tried to cover probably way too much ground, but I just wanted to give you an idea of what was involved in terms of this narrative and that relationship between organized medicine and doctors that supported reform on the one hand, and Douglas and the provincial government, and then Douglas as third-party leader years later in the 1960s. So on that, I want to thank you very much for the opportunity to talk about the book, and I'd be happy to answer any questions.
Thank you so much, Dr. Marchildon. And I have to thank you as chair for staying perfectly on time. I think perhaps the only feat more impressive than writing a 500-page book on Medicare and Tommy Douglas is consolidating that into a 30-minute presentation. So thank you very much. I do see a question in the chat. As folks are gathering their thoughts, I will ask one question that really struck me from your presentation. Tommy Douglas suffered major political losses as a result of his beliefs in his dogged pursuit of Medicare. And I'd like to think that politicians see their job as making policy, but so often I think that politicians see their jobs as gaining votes. And the fact that he pursued the policy at the cost of votes and popularity is really interesting. And I don't know if we see that all the time today. So I was curious, what do you think fueled his really dogged pursuit of universal health insurance within Saskatchewan and beyond?
Well, first of all, I mean, he was pragmatic enough to know he couldn't always lose, or that if you didn't have a social democratic party pushing this, no one would be pushing it, and therefore it wouldn't probably emerge, certainly not in the form he wanted it to emerge. And our system would have looked much more like the US system, I think, with targeted programs and subsidized private health insurance, if the two establishment parties had been responsible. But at the same time, he knew that there was a political cost to pursuing a policy that divided people initially, the idea of it as opposed to the reality of it, and that there would be many that would take advantage of this fear. And that's exactly what happened. As far as the doggedness goes, he also used universal hospital coverage very effectively to regain office in 1948. So it could work the other way too. But he strongly felt that the timing would have to be right. Here's the pragmatism, that you had to be, in a sense, a very idealistic leader in order to provide the vision of what you wanted, to bring people along in terms of that vision and the values underpinning it, but also what I would call the nature of the actual plan and the principles underpinning the plan. But then you needed to implement, and you had to have a program that was very workable. And the leadership there was multifold. The first thing is to bring in the individuals with the ability and the know-how to work out the details and then to manage the program as effectively as possible. The next thing is the leadership to understand timing. Universal hospital coverage, if he could have, he would have launched it in 1945, but it just wasn't ready. The hospitals weren't ready. The system wasn't ready in terms of the number of beds in hospitals, but he knew he needed to have it off the ground no later than January 1947, because that was a year and a half before the next election, and people had to have at least a year and a half of experience with it to be able to decide whether it was a good program or not. He was convinced that they would come on side. And he was right. And he ran the campaign and he won in 1948, and he ran it on the program again in 1952 and won an even greater majority. So in a sense, he knew that it would be a political success as well as a policy success, but it needed to be implemented. The problem in 1962 and the end of 1961 was timing. The doctors knew what they were doing, and they blocked the Thompson Committee from reporting on time, and he was about a year off schedule. He wanted the plan implemented about a minimum of 6 months before the federal election so people would have experience with it. And he wanted it implemented at least 2 to 3 years before the next provincial election. But that timing was undermined by a very astute operations of organized medicine in Saskatchewan. They knew how to defeat him. So those are some of the lessons. I would say that the only other thing is I write a fair amount about this, his negotiations with the stakeholder groups, particularly the College of Physicians and Surgeons, and the lengths he went through to get a compromise with them. At times he was successful, at other times he was not.
Great. Thank you very much, Dr. Marchildon. I see 4 questions so far, and some kudos from Gerald Bowen, a CDM board director from Saskatchewan, for a great presentation. But the first question up is from Karen Palmer, who says, doesn't it seem ironic that a compromise for doctors in the Saskatoon agreement is that they had no choice but to accept fee-for-service over salary, yet now at least some doctors are calling to replace fee-for-service with salary or contracts with the same benefits as employees, like pension or vacation? The times have changed.
Yeah, they certainly have, because I think that fee-for-service was seen as the bedrock of what we call the business practice of doctors and the business autonomy of doctors. Forget about the clinical autonomy. That had been accepted by Douglas. The question was the business autonomy of doctors. And all that Douglas could argue was that at least leave the room open in the future for different forms of payment, such as salary and capitation. But of course, the college did everything it could to squeeze that and to prevent that. And the Canadian Medical Association, that was absolutely central to their arguments for the next 2 decades. But in the last few years, that has not been as hard and fast a position.
A related question from another attendee. Can you say more about how fee-for-service became so entrenched?
It became entrenched because the funding model for Medicare became one of Medicare billing numbers based upon a fee-for-service system. And unless you got paid that way, unless the service was delivered in that way, it was very difficult to make it a free service under Medicare. So unless the doctor, like a radiologist, was hired by the hospital and the hospital was paid under the hospital plan, there was no way to pay that doctor except fee for service. And a very interesting story is the community clinics. They were forced to accept fee for service for the first 14 years, basically, of their existence, because there was no other way to pay the doctors through that system. The government could have negotiated a global payment system, but the college made it very clear that they would hold the government to ransom if it ever did that, while they conducted their own campaign against community clinic doctors to get them out of the system, including preventing them from getting hospital privileges.
Makes sense. Thank you. We have a question from Catherine Bennett. Can you describe the public opinion of the universal healthcare options?
The public opinion. Well, the public opinion, I'll talk about medical care only because hospitalization was not nearly as controversial. So let me talk about medical care. The public was presented with 2 fundamentally different design options. One was Douglas or Saskatchewan style Medicare, which was single payer and single tier. Single tier in that it was expected all doctors should be part of the system. Just ignore the fact that some of them could opt out if they wanted to. In reality, none of them did at that time. They couldn't make a living in Saskatchewan really as opted out doctors, so they didn't do that. But the idea was you wouldn't have doctors solely practicing in the private side and doctors solely in the public side. They would all be providing Medicare services, right? And that was certainly true in hospital care. All the hospitals participated. Everyone could go into any hospital in the province. And that's the model that became dominant in the rest of the country too. So that unlike Australia, unlike Europe, many countries in Europe, unlike New Zealand, there are not two tiers of hospitals. And there are not two, in a sense, distinct groups of doctors. So that's the single tier principle. The other alternative was basically a multi-payer system that was administered by the private health insurance companies. And then those who could not or could prove they could not afford the premiums would get a subsidy from the government, and they would then be able to purchase the premium for insurance coverage from the private health insurance company. But that also meant the hospitals and doctors had choices within that system, and they could basically choose not to accept people that had subsidized private health insurance, or they could choose basically to provide services to people with insurance, but extra bill on top of the insurance coverage that was provided, or if they felt that the public subsidy was too modest, they could insist on extra billing the patient above that. And again, that is a very common system in a number of countries. You see that in the United States, you see that in New Zealand, Australia, you see that in a number of the continental European countries, not in the Nordic countries, and it's limited in the UK, but it's more common than not. And that was the option, and the example was an actual working model in Alberta, both for universal, or not universal, but both for targeted hospital care in the early 1950s, and then something called Manning Care, named after Premier Ernest Manning, from 1963 until he joined the national system in 1969, in which basically private health insurance was subsidized.
Thank you. I'll briefly direct everyone's attention to the chat where there is a link where you can buy Dr. Marchildon's book to read more. Don't be intimidated. It is a big book, but it's very fast paced. Every page has a new political upheaval or some major chapter of Tommy Douglas's life or the quest towards Medicare. We were talking about how it would make a great CBC miniseries. So you can comment your ideal casting in the chat if you'd like. And I did want to direct attention as well to a link from Sarif Ahmed, our national director, if you're interested in supporting Canadian Doctors for Medicare, so we can continue to run events like this. I do see questions from Keith Lowe and from Annika Lorberg, but I'm going to combine a question from Ann Dawson and Catherine Servin, just because I think we only have 3 minutes left. And that question is, what do you think are the most important lessons from Tommy Douglas today as we struggle to improve Medicare and how we often feel like we're losing so much ground? What do you think are some main takeaways for today's advocates from his journey?
Perseverance, number one, never accept anything as a final defeat. You can lose the battle, but you just got to keep fighting and you'll win the war eventually. The next one, I think, is what I would call to understand how rapidly the political environment changes, and when it changes, it always produces some opportunity, and to take advantage of that. So those are at least two lessons. There's probably many more, but I would argue that he would also say that the principle is essential to this all, that values are critical, and that compromises are sometimes necessary, but they can't go to the heart of what you're trying to achieve. You might as well not even bother if it undermines the original purpose of what you're trying to achieve. And he always held on to that. He always compromised where he thought the compromise was possible and didn't undermine the objectives of the program, but he would not compromise on the essentials.
Thank you very much. I mean, that's an amazing note, but we still have 60 seconds left. So I'm not sure if it's fair to ask a question, but I will briefly ask Annika Lorberg's question. How were other countries doing in Europe at this time? Were they ahead or behind of Canada? Were there doctor strikes in other places? Or was this kind of unique to Canada at that period?
Well, it's a mixed bag. Some of them were a little bit ahead. Many of them were behind in terms of universal health coverage. But in terms of doctor strikes, there were only very rare instances of this. I did a comparative study on, there was a major strike in the early 1960s in Belgium that resembled very much the strike in Saskatchewan. And so I worked with a colleague in Belgium to compare the strikes. And we found that what was motivating them was very similar, and that the ideology supporting organized medicine, that ideology of what my co-author called medical liberalism, really, it was more explored in the Dutch case, but I really saw how it fit the Canadian case as well.
Thank you. Good to know that we're not unique in that sense. We are officially at time. I think many takeaways from this presentation, but I'm reassured that we have to be dogged and determined in our pursuit of policy change, and that compromise is okay as long as it does not sacrifice our ideals and our principles. So I think that's a powerful note to end on. Please, everybody, join me one last time in a virtual round of applause for Dr. Marchildon for very generously giving up his evening. Again, if you would like to purchase the book, Tommy Douglas and the Quest for Medicare in Canada, you can see the link in the chat by University of Toronto Press, very easily Googleable. And you have all our information on our CDM website for how to support our work or join if you're not yet a member. Thank you very much, Dr. Marchildon. I see lots of kudos for you in the chat.
Well, thank you very much.
Thank you, Mel and Mr. Marchildon. I'm going to close the webinar, so it will abruptly end the Zoom window for all of us, but we can continue to correspond via email. Thank you again. That was absolutely amazing.
Thank you.
Good night.
Good night.